Good morning, and thanks to everyone for joining us. I hope you're all keeping well. We have some technical problems this morning. PC Providence Care Hospital, where our panelists are, is having some difficulty with their server. They're going to try and reboot it just about this time now. So we're going to go ahead and hope that they finish that and the problem will be rectified by the time that I finished my words to you this morning. I'm John Leverett, a member of UHKF's Board of Directors and your host for today. I'm a retired professor of psychiatry, a child and adolescent psychiatrist, and served on the medical staffs of KHSC and Providence Care for some 45 years in clinical and administrative positions. Just to remind everyone, this webinar is being recorded and it will be available on your website and on our website and YouTube channel. There'll be time for questions at the end of the presentations. Remember, you can ask a question at any time using the Q&A feature at the top of your screen. Just type your question in the box. You can ask your question anonymously if you'd prefer by ticking the box at the bottom left. If you have the same question as another attendee, simply click the thumbs up button to show that you'd like that question answered too. We expect the webinar will last about approximately 45 minutes. If we don't have time to answer all of your questions, we'll email the answer to you after the event. You're here because you're among our most valued donors and volunteers. So thank you for your continued generosity. The Circle of Care events are held 3 times each year, and although we're not able to have them in person right now, we're happy to be able to connect with you virtually. The purpose of these Circle of Care events is to provide donors like you who are at the Champion or Ambassador Who Care annual giving level and our Evergreen members who have confirmed a legacy gift, a special opportunity to connect with some of our outstanding healthcare providers. And today, hopefully, we're very fortunate to have Dr. Simon O'Brien and Ms. Gillian Mclean with us. Dr. O'Brien was appointed the Psychiatrist-in-Chief at Providence Care on April 1st, 2019 for a 3-year term. And in this role, he oversees the entire clinical portfolio of mental health services associated with Providence Care, both at the Providence Care Hospital, its adjacent facilities in KFLA, as well as Providence Care affiliated regional outreach programs. Today, he's going to share with us how COVID-19 has impacted the mental health patients and programs in our region. And following Simon's presentation, Gillian, a spiritual healthcare practitioner at Providence Care, is going to share some strategies to help us cope with the pandemic. So hopefully at this point, it's over to Dr. O'Brien.
I do see, I think that's Dr. O'Brien in Gillian's little square there. Would like to go ahead now?
Just
Gillian, you need to unmute yourself. We see you, Dr. O'Brien. You can go ahead.
okay, we're having technical problems. Just give me 2 minutes. I got to get my slides and my camera. I got to just get it to a camera that's working. Just be 30 seconds there. So I think, as I say, we had apologies, major technical issues today with our server. So I think I've got most of my slides back, but perhaps not all. But can you hear me okay?
Yes, we can hear you great.
Okay. I'm just going to screen share. And so can everyone see the slides okay? As I say, we're having a lot of technical issues, but if you can see them, I'll proceed. If you can hear me and see the slides.
Yes, we can see the slides.
Okay. So thank you very much. Good morning, everyone. Apologies for the technical problems. So I was kindly asked by the organization to give a brief overview of Providence Care's COVID-19 pandemic response. And it's very timely because just as we thought we were perhaps getting out of the second wave, we're clearly into the third wave. And so I'm going to briefly just go over the hospital's response, how we responded to the community crisis while trying to maintain our regular services and not build up wait lists to make sure that people can get the care that they need. And it's certainly been quite a challenge. In fact, just this morning, one of our roles is to keep flow going. We were told we were going to be taking a large number of patients from Champlain, Lynn, or Ottawa, which is something we've been doing, taking patients from the GTA or taking patients from KHSC to try and keep provincial flow going, which is a different role than just locally helping out. So I think, as most of you know, Providence Care, our regular services pre-COVID involved inpatient rehabilitation, obviously, for stroke, brain injury, spinal injury, our large inpatient palliative care services, and our large outpatient mental health services with many teams that follow hundreds of patients with various mental illnesses, severe depression, bipolar disorder, manic depression, schizophrenia. And Providence Care tends to follow patients that are quite persistent and severe in their illness. So people that may have been tried in an acute system and their needs are much higher. We have large physical medicine rehabilitation programs, ALS programs, our seniors mental health programs, obviously with dementia and Seniors Day Hospital, and the care of the elderly is also a big part of what we do, along with inpatients, adult inpatient mental health. So these are the services that we really don't want these populations to lose out. It's very easy to lose sight of the total cost of a pandemic. If you look at pandemics throughout history, when the history books are written about them, it's not just about the number of COVID deaths or COVID hospitalizations. It's about the people who died when they couldn't get their heart valve replaced because of the wait list. It's about the people who died of cancer because they couldn't get their cancer screening. So if you think about the domino effect of a pandemic, it's really also about not just the direct deaths and morbidity and mortality from the virus, in this case COVID, but all the trickle-down effects on the broader population in our region and in Canadians' health in general. So we have our eye on that, and we really want to make sure that we can still deliver services and play a role, for example, to allow KHSC to expand beds in ICU and critical care for COVID, but also be able to have post-operative patients function, for example, by taking them here. Our new hospital design put us in a very good position. Initially, we thought of actually taking a lot of COVID positive patients because we have 100% private rooms and they're private washrooms also. And we've got a lot of modern positive air ventilation systems and very state-of-the-art sanitizing and hygiene systems because of the newness of our hospital. However, the ICU capability, obviously, of KHSC made it more sense for acute COVID patients to present to the acute hospitals. We have had patients who have converted COVID positive at Providence Care, and as I say, we are able to manage them quite well if they don't need the ICU, just because of the intrinsic design. So we normally have about 270 funded beds that we were operating prior to COVID, and one of the things that we did was to create unconventional beds. So we actually have the capacity to go up to about 204 beds off service, quite literally, and I'll show you pictures, in corridors and sunrooms and hallways, to predict a possible crisis need where we would either have to decant patients from acute hospitals all over Ontario or provide direct care. So in the first wave of COVID, we took 23 patients from KHSC to allow them to open up beds. And we've been taking patients in the second and third wave from GTA, and then, as I say, today we just got an order to take some from the Champlain Lynn in Ottawa. So we actually use beds that are off services. This is actually a lecture hall where there's rounds and conferences in Founders Hall, and we really had set up beds tent style, including borrowing some mattresses from Queens and residents and being creative like that. So we were able to create the beds, and if we have to, we can up staff to handle a large number of patients who are not on conventional wards. One of the areas we paid a lot of attention to, though, as I say, is marginalized populations that we serve in the community. And if you think about it, like the global effort towards COVID and locally is only going to be as good as some of the most vulnerable groups' immunity is. If you have large groups of people, whether it's students, people with substance use, people with psychotic disorders, homelessness, who cannot follow the rules and distancing and isolation protocols, may not even have phones for public health to contact them, or people who are not going to be able to get vaccines because they're paranoid of the vaccines, for example, from delusions, then it's going to be very difficult to get control of COVID in the general sense for anyone. So we put a lot of effort into populations that tend to be non-compliant with medications and that are quite vulnerable. Just to give you an example of some of the scenarios we deal with, as I say, it's fine to set up rules to have in-car screenings and COVID tests and follow public health guidelines for most people. But many of our patients have severe psychotic symptoms. They themselves may not believe they could be ill. They may have delusions that interfere. We had a lot of issues with the masks. A lot of people that have paranoid delusions are quite frightened of being suffocated by masks, or people with severe brain injury, intellectual impairment may not even know how to properly wear a mask. So even simple things that have actually been responsible for reducing COVID spread in the last year may be difficult for certain groups to be compliant with. For example, many patients, when we ask them to wear a mask, would say they can't breathe. They would want the mask off, which puts staff at risk. They wouldn't understand how they could eat with it on. A lot of medications for people with severe mental illness are delivered once a month or every 2 weeks by an intramuscular injection, and that really keeps people well and out of hospital. However, when the staff, who they know for years, show up in full PPE and masks, again, many patients with mental illness get extremely frightened. They think they're gas masks. They think we're coming to kill them. We've had patients who will try and flee on buses to get out of Kingston because they feel we're after them. And so these are some of the challenges. Sometimes they'll then move very close to us to try and get a look at our faces to make sure we are who we say we are. And they will then not be compliant with their regular treatment. Now, the issue with that is if we have hundreds of people decompensate because they're no longer on their psychiatric medications, where do they go? They go to the emergency room at KHSC. And that's the last place we want people to clog up when we're dealing with a pandemic. So we put a lot of effort into trying to be creative and come up with individual personalized plans to keep really every one of hundreds of outpatients as well as possible and compliant with public health measures and stable. looking at drug and alcohol use, which we know has gone up tremendously in the student population, in the general population with isolation and quarantine. Looking at lifestyle, things that kept people well, getting out, going to the Y, seeing friends, things that are good for your mental health, exercise, suddenly no one can do. Everyone's saying stay inside. And these are groups of people we may have worked for years with just to get them to go out and be social. So we tried to look at all these aspects of how to stay connected, how to stay on top of their medical health, because no longer can they see their family physician, how to get the medications, and how to be compliant with medications. Unfortunately, with our tech issue, I don't have the support tool, but we developed an individual tool that actually took stock of people's knowledge of where they were at with COVID. Where do they get information? What do they fear about it? What do they think? What rules do they think they have to follow? And so for every patient, we had a personalized plan. Now, one of the interesting things is, if you think about it in yourselves, although it may seem familiar now that you can easily estimate 2 meters or 6 feet, in fact, studies show that most human beings are quite good at estimating that vertically, because we think of people as being 6 feet tall. We're actually all quite poor at estimating it on the horizontal. And when we looked at our patient population using just mannequins and asking them to put 2 mannequins 6 feet apart, we actually found that about 64% of people were below the 2 meters or the 6 feet, and about 8% got it right, and a few were actually above. So if you think about it, if social distancing is the main thing that actually reduces spread, along with masks, and 2/3 of a certain population group doesn't know how to socially distance, that's going to be an issue. So we actually used mannequins. We created a virtual lab and mannequins to really show the distance. It sounds simple, but in a hospital setting, if you have people with brain injury or dementia or psychotic disorders or who are manic, that simple measure, being actually able to know what 6 feet is, allows them to be able to go off the ward safely. Many people do not have video technology in marginalized groups. And one of the ways that all hospitals adapted was to give care virtually, which is fine if you have iPads and computers. But in fact, what we found is that 85.6% of our population didn't have the ability to connect, but yet 61% of them would accept that. So we actually made sure by direct purchasing and distribution of some hardware that people actually had the means to get information, to keep appointments, to be able to link with the healthcare teams, to not put the team at risk, which again can then spread it throughout Kingston, and to be able to get help and support and stay well, even if they weren't used to the technology. So we put a lot of effort onto a virtual plan to allow people to get up to speed on technology and use it and get the support that they need in groups that don't have it. So a lot of our rehab has gone virtual. In fact, being able to do things that we would have thought would have taken 10 years to do, we've had to fast forward. So being able to give physiotherapy post-stroke virtually has been successful. Many family meetings we've gone to virtual, and many follow-up appointments. Although you have to see a doctor in person for a physical exam, a lot of interactions, follow-up medications, adjusting doses, how are the side effects, can be done virtually. It's been interesting because being able to see people's houses, for example, with cognitive impairment or elderly with dementia, with the cameras on their iPads, we can often have a family member scan the kitchen and we can spot safety issues, things that we could never do with an in-person appointment. Even things like some of our spinal injury clinics and functional recovery, we were able to switch to virtual care. A lot of our teams and care delivery is multidisciplinary. We'll have, for example, neurologists, respirologists, palliative care, resp therapists, OT, occupational therapy, physiotherapy, speech language pathology. And really almost all the specialties have been able to deliver some of the care in a hybrid model virtually, which some patients prefer in terms of the distance. And it just allows people to not have to have wait lists to decompensate, go to the emergency room. They can still get care and stay on top of their conditions, which is equally important to us, along with helping out directly with COVID. All our orientation for new staff, we were able to pilot virtually, including some of our teaching through St. Lawrence College, and some of our nursing students, we were able to provide reasonable experiences also virtually for learners. So looking forward, as I say, as we enter this third wave, one of our big roles is in maintaining flow in the system. We have the extra beds. Our staff are highly motivated to take on the extra patients, to step up and really serve the region and also the province in order to allow other people to get the services they need in the right time, whether it's surgeries or different services. We are also looking at, obviously, our virtual care in this third wave, really trying to expand it. The irony isn't lost on me that I had problems with tech getting through to this talk, and we're talking about our virtual ability. But we really are putting a lot of effort into having the virtual experience be very user-friendly for people of all ages and stages of life and all tech capabilities. And that can be as simple as having IT support in the moment. You can't wait 40 minutes if your appointment's only 30 minutes long, or being able to have the hardware to allow for virtual interactions with the healthcare providers. Providence Transitional Care Center, we're very excited in terms of opening up and being able to use that, again, as another source of beds and to care for patients in the region and allow more flow within the system. A few slides are missing because of our tech issues, but essentially that's really an overview of how we see ourselves in terms of our role positioned with our partners in the region, and then more provincially right now as we get provincial orders to take patients and then try and maintain delivering healthcare to the populations that we normally serve. And I'll just stop the screen sharing if I can.
Thanks, Dr. O'Brien, or as I would prefer, Simon. Thank you, Simon, and really for your leadership and innovation, not only for mental health patients, but also in maintaining patient flow to assist patient care in all the medical and surgical domains. I'd now like to invite Gillian to speak.
Thank you, John. Are you unmuted? Is it mute? Do you want to come to my office? She might, if she's having trouble, she'll just come down to my office and use my computer if you give her 1 minute. It just looks like she's on mute. Is Jill? No, it's okay. Okay. It's okay, you can use that. It should be good to go there. The mic's there. It's a huge mess, but you can't see the camera.
Yeah, I didn't have the...
No, it's okay. Were you just on mute, or was it not working?
It's not working.
Okay.
We set it up with different...
Yeah. Just put anything on top there. Apologies, it's a huge mess. It's all good. We've had such...
Am I on mute?
No, I think you're good. If you look into that camera.
Good morning.
You can just double check this.
Can you hear me now?
Yes, we can.
It's interesting preparing tips for managing stress associated with COVID. I think the last 20 minutes for me have been very stressful. So thank you for bearing with me. And I'm borrowing Simon's computer. So I'm grateful to be able to share some tips for managing stress associated with the pandemic. I'm going to share some activities that I've used over this last year also, and suggest some ways that are available to any one of us as we cope with the stresses associated with our current circumstance. However, I'm also hoping that I can perhaps convince you that perhaps COVID offers us an opportunity to have a reset button for life in general, and to begin to live differently. So I think it's fair to say that since March last year, we've all been facing remarkable stress landscape, whether it's the nature of the stresses that we're facing, or whether it's the exceptional quality of our own circumstances during lockdown, or the challenges that our family are facing. I think so many aspects of our lives have really been affected. Our lives have been interrupted, and I think really we're on almost a stress odyssey. We're stressed about ourselves, we're stressed about our families, and we're stressed about our friends and the world in general. So how do we embrace the stresses that are involved with COVID and choose to live as well as we are able? Recently, I was listening to an interview with Dr. Richard Bentel, who's a clinical psychologist from the University of Sheffield in England. And he's part of a large research team who are investigating the impact of the pandemic on mental health in the general population. They surveyed 2,000 people, and they found that the initial wave was really resulted in a 40% increase in depression and anxiety. However, subsequent waves have impacted people differently. And in fact, they found that 60% in subsequent waves of the population is really very highly resilient. They've got stable marriages, stable jobs, and they're able to manage the stresses associated with the pandemic well. 25% of the population experienced an increase in depression and anxiety, but they were managing. Often these are people who are perhaps more vulnerable to the chaos and sense of fragmentation. Those with young children, those with perhaps some economic issues, or young people in higher education or seeking employment. These people are perhaps more vulnerable. 10% of the population did better, interestingly. And then the 5% of the population do very poorly. And largely this is the population with existing mental health issues, or young people who really don't have the strategies to cope with stress. And one of the things that Bentel really highlighted in his talk are just the challenges associated with loneliness, which is such a prevalent piece of this pandemic. And he really identified the importance of fitting in and belonging, and thus the need to connect that we all have. So I think also it's important to note at this point that the pandemic is part of two larger crises. We have an ecological crisis and also a lifestyle crisis. I think for many of us, our pace of life is unreasonable. And so both of these crises are ones of connection. We're sort of disconnected from ourselves, from the people around us, and from our world. In Chinese, there's a definition of the word crisis, which says is a crucial point when things begin to change. And so maybe the pandemic is an opportunity for us really to hit a reset button. So I was thinking about this morning, and I think it's safe to say that I think we all want to go back to normal, just as we're now probably entering another period of lockdown. But what sort of normal do we want to get back to? When it all ends, how are we going to do life? How are we going to find a sense of balance or create conditions where we can flourish? How are we going to care for ourselves in a way that we can be authentic and do the things that we value? And basically, how do we create a new normal for ourselves? How do we best use this time to do something that is useful and healthy, and not just sit around watching movies or the news and eating junk food? So I think isolation has, so far over this last year, it's demanded of us. There's been a huge price to pay, and yet there's been some things that we have seen over this last 12 months where we've seen a huge increase in creativity and an increase in collaborations. I think in general, people are learning to connect with communities in new and unexpected ways. We're discovering new things about ourselves. We're learning flexibility, and we're realizing what we do cherish and enjoy. So in practical terms, what can each of us do to live well and to build a capacity for resilience in our lives? I think for me, living healthy really means to slow down and begin to notice the world around me. So it means connecting with myself, connecting with those around me, and connecting with nature. Many mornings I begin my day in silent contemplative prayer, and this period allows me just to quieten my mind, and it sets the tone for my day. And then regardless of the weather, I walk, and often my preference is to walk down by the lake or in the woods. And it's in these wild places that I know, for me, that I gain a sense of peacefulness and calm. And I think, like many of you, COVID is really causing me to step out and to try new things. So I'm discovering new gifts, a brief foray into acrylic painting, and I've discovered old gifts. Last summer, I dug out some knitting needles, and I think in the last 6 months, I've made more toques than I have in the last 20 years. I've chopped my first batch of marmalade in 5 years. But those are things that I do, and they work for me and my family. And you're maybe thinking, well, that's fine for you, but I don't like marmalade. So I sort of encourage you really to name your own stress busters, ways that are unique to you, ways that help you to connect and to be present with the life as it unfolds. By all means, go back to your old hobbies, things that you love to do. Lose yourself in a book, in the daily crossword puzzle, bake some muffins. But why not use the opportunity to perhaps do something new, something that stretches your limits? Maybe something that you've been considering for years. Start growing orchids, start experimenting with calligraphy, take an online course, feed the birds, learn an instrument, learn to meditate. Be curious about yourself, perhaps do something that scares you, and be willing to make mistakes. I think one of the things I often say to patients is, don't focus on what you can't do, but simply focus on what's available to you. Choose what to invest your time in. Choose who you invest your time and energy with. And perhaps learn to let go of the things that are no longer serving you. I think one of the big things that I certainly see in the mental health units is that the people who have more resources have an increased capacity for resilience. And so for those of you who perhaps want some more suggestions, I'm going to give you a few more things that perhaps might spark some new ideas for you. One of the big areas is really to connect with your own creativity. It doesn't really matter what you do, doodle, sketch, paint, but research has shown that even simple coloring will reduce anxiety by 25%. So choose your art form, compose poetry, write, make music, listen to music. All of these help to give form and voice to scrambled thoughts and emotions. They allow us to redirect ourselves to a quieter and calmer world. Connect with your garden. Get some dirt under your fingernails. And if you don't have a garden, get a pot on your windowsill. perhaps propagate some seeds. It's fun giving away seedlings and plants to neighbors. Again, forms of connection with others. Connect with your body, and doesn't matter how you move, run, walk, swim, go to the gym, do yoga. At work, I host a yoga session for staff for about half an hour, one lunchtime a week. We use social distancing, masking, and then we laugh a lot at ourselves and each other. Doesn't matter what you do Tai Chi, have a dance party in your kitchen. Again, research has shown that exercise is one of the things that releases so many natural endorphins, and it helps and boosts our mental abilities. One of the best single things that any one of us can do is actually to walk. And it doesn't have to be a marathon. Just half an hour a day will improve our mood by 25%, and it reduces anxiety by 40%. And walking grounds us in reality. It calms our gray matter. And as you walk, I always tell people, be mindful. What can you see? What can you smell? What can you hear? What can you sense? What can you touch? As you walk, maybe smile at a stranger, say hello to the people that you pass. Walk with people, walk with your son, your daughter, your parents, your friends, your neighbor's dog. Walk in nature and watch and learn from the wild creatures of our world. Maybe later on this year is the year that you sign up for the Frontenac Challenge. Perhaps it's something that you've always considered. Another important piece is just to remember to care for your body. Feed it on a regular basis. A low blood sugar is going to elevate your anxiety. The occasional glass of wine or a beer is not going to help, not going to hurt, but remember that too much alcohol is a natural depressant and is not going to help your sleep. I'm big into self-compassion these days, so I encourage each of us to be kind to ourselves. Do the things that you love. Enjoy a bath, a shower. Try a new variety of tea. Watch a comedy sketch. I love Robin Williams. I can't get enough of him these days. And get enough sleep. One of the things that we've seen over lockdown is so many people are buying pets, and there's been a huge increase of the number of dog owners and cat owners these days. And another form of connection, connect with others and talk. I think COVID has really prompted me to be much more intentional about talking with the people that I care about. Our family don't live in town, and so we spend a lot of time on FaceTime and in phone calls. I have a weekly Starbucks date with my daughter in Hamilton, who so we synchronize watches at 7 o'clock in the morning, and when I'm two blocks away from Starbucks, she orders the coffee, and then we walk and talk on my way to work. So spend time with your family, with your friends, with colleagues. Reach out to the neighbor down the street. You never know how important that's going to be for either you or for them. Phone up an old friend and have a cup of tea together. Arrange a Zoom meeting with your book club, with your knitting circle. And when the weather warms, host people in your garden. There's so many things that we can do that are possible, regardless of whether we're in lockdown or not. And if you recognize that you or someone close to you needs help, please don't be afraid to reach out. Help is available. And finally, connect with yourself. Remember, this pandemic is going to be an endurance event, and be mindful and attend to your own needs. So be gentle and don't forget to breathe slowly and deeply, and then you take another slow, deep breath. Thank you.
You may have a question too, Fraser.
The screen is frozen.
Oh.
Thank you. There are a couple of questions.
They can still see them. It's not frozen.
Okay.
I don't know if you're able to see them or if you'd like me to read them to you.
I'm not able to see the questions at present.
Okay, so I think the first question is for Dr. O'Brien. You mentioned you are buying hardware for clients to connect using tech. Does this mean you're buying phones and tablets for your community clients?
Yeah, one of the things we've been trying to look at is what actually is the best platform, what is the best technology to use for healthcare visits. And probably it's iPad seems to be. So for some populations, the hardware is the issue. For other populations, the hardware is not the issue, it's the tech ability, especially for elderly generationally. For some, it's actually service and Wi-Fi connections. And so it's different for different populations, but yeah, we had to invest in some actual hardware to allow for healthcare, or people would have ended up in the emergency room or much worse in terms of their conditions.
Thank you. And the second question is, first, thank you for the amazing work and care you all provide. I'm just wondering, with the amount of new inflow from other places, if the vulnerable patient population affected in regards to the care, since the staff capacity might be at its limit. Hope this question makes sense.
Can you repeat it one more time?
Sure.
I wasn't. Is it the idea that other groups could deliver virtual care, or so I didn't quite follow the question, but one more time and I'll get it.
With the amount of new inflow from other places, if the vulnerable patient and population affected in regards to care, are they affected since staff capacity might be at its limit?
Yeah, no, okay, sorry, no, I do get it. That's an excellent question. And one of the things we've really been looking at is the ethics, the complicated issue of the ethics of taking patients. So for example, if we, when we expand our beds to take extra patients, it really helps out the GTA and helps out our healthcare partners. And we want to be good citizens to the province. And as I was saying in the talk, if we help control COVID overall, it does help all of us. But Toronto and Ottawa may have other clinics and facilities, for example, for, I'm just going to use ALS, Lou Gehrig's disease. We have a large clinic-large population. So if we put beds in that clinic and we can't serve people, or our staff are busy, there's no other resource in Kingston for that group. And yet a hospital in Toronto may be doing the same thing, but they can go elsewhere. So we've really put a lot of effort into the ethics of populations and how do you make the decisions to serve and not have people lose out. I think it's fair to say thus far we've done a reasonable job at it. Some people, there's no doubt, would lose out on service temporarily, but for emergencies, and we try and stratify groups into those that their conditions can't wait a few months, those that could, and then longer, and still provide even face-to-face service, just using a lot of precautions for some groups. It's very difficult because the more you wait, even though you may not be an emergency today, if you don't treat something in 4 months, you are an emergency. So it's an issue everyone's had to deal with. I think the best answer I can give, it's something we're very aware of, is the domino effect and trying to represent all the groups and yet still trying to step up in the time of a crisis. And we're trying to reach that balance sort of reflectively and thoughtfully, really through the sort of the ethics of our decisions and making sure we don't just help one group and then another group loses out, and it's how to balance that. So it's ongoing, and it's something we're aware of, and there's no perfect answer to it, but we're certainly grappling with it in the best way we can.
There is another question that's coming through the chat. She's wanting to know, has there been any specific mental health care upgrades for maternity postpartum, and especially situations such as stillbirths or NICU? Not sure if that's something that you would know.
Well, it's a great question. There's, in the last 10 years, the recognition of maternal health and the postpartum period, and whether it's a loss of a child, stillbirth, or just postpartum depression and all the issues in general, has got a lot more focus, funding, and programs. So for example, one of the main programs for that in our area is actually at Hotel Dieu. And there's one or two psychiatrists who are just operating a women's health program where they would see a lot of those resources. Providence Care's role isn't specifically in that space, other than in refractory cases. So we are a specialized regional center. So if someone's depression and mood wasn't getting better, we would see them. But in general, I think it's fair to say that there has been more services for that group really through the acute hospital in Kingston through Hotel Dieu and Dr. Eric Prost Clinic. Having said that, with COVID, we know that everyone's lost out in terms of the resources and things. And so that group also would be affected by that. As I say, it's not in the specific Providence Care space, other than we try and work closely with that clinic for very refractory cases because some of the specialized treatment is only at Providence Care. But I know that there certainly has been, like 10 years ago, there was not such a separate service, and now there is. So we certainly encourage people to liaise with that service for any issues relating to sort of postpartum depression, loss issues, child in NICU, because it's such a huge area affecting family systems and obviously the individuals, and there has been a lot more focus on it.
Thank you. Have community GPs been facing increased numbers of patients required to be off work due to mental health issues throughout COVID?
Again, we have a lot of, I don't profess to have the firsthand knowledge for the community GPs. We have quite a few hospitalists that are GPs that have their own clinics and practices and work here. There's no doubt that some people are off work simply through quarantine screening. They've had exposures and therefore had to be off work. And yet, even for people who are having to work at home, we know that, as Gillian was saying, like the incidence of depression, anxiety, which are huge illnesses that affect work productivity and workplace function in general, even in the pre-COVID world, they're actually the top causes of disability. They've risen. And there's no doubt like people are anxious partly for good reason. And some people's anxiety is heightened. They're overly fearful of certain things that COVID's really exacerbated and the precautions. So I think it's fair to say there's certainly been more people off work, both for the screening reasons and quarantine, but also for the direct, the secondary mental health reasons. And people struggling through work who can't work as well because they're worried about their kid at school, home learning. They're worried about infectious catching COVID. They're concerned about their partners and family. They're worried about their mother they can't visit in a nursing home, etc. So all these things factor in. So even for people who are struggling through work, productivity, concentration, and ability is down. And so stress leave is certainly up. And I think it piggybacks to what Gillian was saying is I think we have to be accommodating and mindful of that, and workplaces have to realize that and be able to accommodate, even though their numbers have gone down, which creates stress on the remaining people. And that's part of the sort of coming together to solve problems, in the pandemic system. But without doubt, occupational function across the board is being affected, both people off and who are still working.
Thank you for that. We did have one question that came in ahead of time. This person is a power of attorney for a person who suffers and has suffered from depression for many years. After spending several weeks on Burr 4, the patient is now in a retirement home. The person is continually asking to speak to a doctor at Providence Care. However, doctors do not visit in any form retirement or long-term care when the technology is there to use. So her question is, why can't video appointments be arranged with these people?
Right. Yeah. And I had the luxury of looking at that question. You'd kindly forwarded it to me ahead of time. So, so Providence Care teams and physicians, as I said, are doing a lot of video appointments and care, and especially in our geriatric psychiatry and seniors mental health, because the long-term care homes and retirement homes were at such risk of people going in and out. They were super strict on not wanting healthcare providers who worked in more than one setting to set foot there. So in fact, our seniors and geriatrics teams have really adapted to that virtually. So I'm just thinking of this specific person's experience. So I don't think it would actually be an issue around the technology or the service that we're providing, because we're doing that virtually to long-term care and retirements. The only thing, and I can leave you with some contacts after to solve it perhaps individually, is that Providence Care's role is quite specific. And if someone's, say, on BUR 4 in the acute system, their follow-up may not have fallen to Providence Care. And they're asking to speak to someone from Providence Care, and they may see other people in their retirement home getting care from Providence Care. So it may actually not be a tech issue. It may be that either from their family doctor, the referral, I don't know if a referral was sent, or if the referral it's the right clinical picture that Providence Care would get involved. But I'm guessing it's more because of that reason and not the tech issue or our services virtually. But as I say, Marie, I can certainly provide you, Marie, with a number after that this person can call, and we can sort of clarify in a general sense what the issue is for the person they're POA for, because you never know from the question alone, but I'm just guessing there may be other factors, given that we're doing a lot of virtual appointments to those very settings. The person's correct on that.
Sure, thanks. One last question. Could you please repeat the stats regarding those already experiencing diagnosed mental health issues, how these individuals have been faring during COVID?
Yeah, was that some of the stats that Gillian was giving, or?
I'm not sure.
Okay. There's lots of, and I'll let Gillian answer part of that too. There's lots of statistics that have been measured. It's interesting, in the first wave, in the early, the first 6 months of COVID, we saw suicides go up and a lot of anxiety and depression. But quite interestingly, and a lot of the data came from South Korea and some of the countries in Italy that were experiencing it worse in Canada, it was quite intriguing. The suicide rates and anxiety and depression was actually going up in the population that didn't have a mental health history. So it almost seemed like some people with mental illness had some resilience, and people who hadn't experienced anything were actually faring more poorly. And to some degree, that's still going on. Now, as the second wave, and we're getting into the third wave, and it's been over a year, has gone on, there's no doubt that some of the supports and care that keep people well and keep people out of depression and keep their anxiety at bay have changed, and they're not able to practically get their care, and they don't have their support systems. So we've certainly seen rises in that. It's been quite difficult, to be honest, locally to track statistics, because a lot of people, for fear of COVID, aren't going to the emerge to be assessed. They aren't going to appointments. They aren't going to the hospital. There's that phenomenon. And so we know there's more people suffering out there. So I think it's fair to say that we know that suicide rates have gone up in certainly the young population over the last year. We know substance use, alcoholism and drug use, and marijuana use in the young population has dramatically gone up. We know that the incidence of depression and anxiety has gone up. I think the numbers, how much they've gone up, so it's substantial. It's hard to put an exact number on it. And I'll let Gillian answer a bit more, because she had some statistics on that. But we know they've gone up now, both in people who weren't perhaps vulnerable and in the groups vulnerable, and we're certainly seeing suicide rate go up. But I'll let Gillian just answer that too, because she had some statistics.
Hi, I had a couple of statistics. The study that I was quoting was from Professor Richard Bentle in the UK, and it was of a general population. So he said that out of 2,000 people, 60% were extremely resilient, had no difficulty. 25% had increased anxiety and lower mood. 10% had felt that their situation had improved, and it was the 5% that were doing much more poorly, and that was the number of folk with an existing mental health problem. My daughter from Hamilton actually sent me a newspaper article from Hamilton recently, which was some just general stats from a child and adolescent perspective in Hamilton. And they were saying that their numbers of attempted suicides in the younger population had gone up by threefold. Adolescents who are admitted for TAP over the years. So it's the young people who are really struggling.
Thank you, Gillian and Dr. O'Brien. And I think we'll turn it back over to Dr. Leverett for a few closing remarks.
Yeah, thanks, Simon, for taking the time from your clinical duties today to join us. And thank you, Gillian, for sharing these welcome suggestions to help us all maintain our mental health during the pandemic. I certainly took up oil painting and did a portraiture during that particular time. It whiled away a number of hours in isolation. It was well worth it. The presentations today have covered the systemic to the personal. And this gives me certainly a reassurance and pride that I live in a community where the work our university hospitals are doing on our behalf is both innovative and effective as we continue in this pandemic. I want to remind everyone that if there are any unanswered questions, they'll be answered by email in the next couple of days. And again, that this video will be available on our website and YouTube if you want to watch it again or share it with friends and family. I hope you found it interesting and easy enough to participate. It's been a time of change for all of us, and I'd like to take a moment to thank all of you for your outstanding support this past year. And with the rollout of vaccines, hopefully we'll soon be able to return to some semblance of normality. In closing, just some information and a request. First, the UGKF Healthcare Champions are hosting a webinar on April 16th at noon on youth mental health. And Nicholas Axis, the Director of Mental Health Services at KHSC, will be speaking. And you can register for this on our website at uhkf.ca. And secondly, please take a couple of moments to complete the survey that you'll receive shortly. We do plan to do more of these, so we'd appreciate your input in order that we can offer topics that are of interest to you. And finally, thanks again for joining us today. Hopefully, we'll be able to see each other face to face in the not too distant future. Stay safe, get your vaccine when it's available, and enjoy the rest of your day.
Thanks, John.
Thank you.